My name is Flavio Roca. I'm co-chair, vice chair with Sai Ahmad, and we'll kick off with a message from our executive officer, Dr. Lisa Kachnik.
Is this a hybrid meeting?
Yep.
Okay. Well, welcome everyone and our Zoom visitors. So I just wanted to give a few announcements as the executive officer for the group. First, we always welcome new concepts. We are allowed to generate our own, although we need to prioritize from statistical support purposes. But the one thing that we can do, and we've been really successful, are to mine the rich data for secondary analyses that could inform new studies. And so I'm just listing two right now that are hot off the press. One was just published, and Sep, who's in the audience, is our primary author on that. So congratulations. And that was mining our cholangio phase 2 0809 trial. And we actually, what Sep and the rest of the authors found was that having lymph node positivity made a difference and really strengthens the use of chemoradiation in those patients. And then we have an upcoming ASCO 2023 presentation from Samir Patel on looking at chemotherapy dose density for being prognostic for patients that have resectable pancreas cancer. And that was looking at one of our pancreas trials in SWOG. So again, there's lots of support from the committee, meaning the GI committee on this one, but for all of the disease site committees to do that. We actually have Dr. Knopf in the audience, and imaging is, if folks want to sort of mine the images too, we're welcome to do that. There's lots of trials that have rich images at IROC. And I also wanted to remind everyone, because this is like free money. It's called Mad Money. And I don't know if I try to make sure that you all see it. If I notice it, I send it to Sai to send to all of you, because for the most part, if you apply for the money to come to the meeting, you usually get it, because not too many people fill it out. And if there's early career investigators at your institutions, please invite them to come and use this resource. So now the new year of Hope Foundation grants. Was anyone at the plenary one on what's today, Friday, yesterday? And you saw that the first presentation was actually from a Coltman fellow. So again, these are ways to jumpstart either finding data to inform a trial, doing a correlative on a trial, or even to support your salary so that you can do a trial. So the ones that are coming up are the NCORE pilot grant program, and they're really looking for health disparities research questions for that one. Then down below is the SEED fund, and many of us in the surgical committee and other support committees have been successful in this. And this is just looking at preliminary data that might inform a new trial. The impact award on the upper right is a big one. And that one is typically a large imaging study or another biomarker, maybe lab correlative study that again might inform a study. And then the Coltman, which was an example from a Columbia early career investigator colleague presented yesterday, is a way to sort of pay down your salary so that you have time to actually do your research. And I'm not sure if folks, I mean, I've been at SWOG for a really long time, maybe not at the inception of the Hope Foundation 30 years ago, but maybe for at least the career of our person who leads the Hope Foundation, Joe Horn, who's done a tremendous job. And out of all of the 4 cooperative groups, I think we have the best foundation in terms of fundraising, but really giving back to us and the early career investigators so that we can have data to have new trials for our patients. So I ask you to consider, especially when it's next year before taxes, to give back, especially if you were able to get an award or mentored someone that had an award over your career. I actually do this yearly, and you can even go downstairs and do it live. I did that yesterday. And actually, the Hope Foundation is looking for new board members, and that's a really good way to network as well. And it's easy to do. You could just take a picture. It's a very, very brief application. You can say, I support you. And my one bit of recent news, for those of you that are PIs of your site, tonight we vote for the new chair-elect. Dr. Blanky's 10-year term is coming to an end next year. And I'm not sure if you were reading the front line or you even knew this, but they changed the bylaws 2 weeks ago from again, a sort of PI, we call it Board of Governors here, but the PIs of the local labs and NCORs, et cetera, that we can have a co-chair instead of one chair. And I don't know if it's going to be much of a race because it's just two people, because this was created in essence probably for them. So after tonight, these two will be your new group chairs. And it's and these are folks that are here doing wonderful work right now. Dr. Lara is sort of Dr. Blanky's number 2, and Dr. Hirschman's our NCOR PI. So we'll be in good hands for the next 10 years. And that's it. Anybody have any questions? All right.
So in terms of our surgery committee proposing studies and statistical support, would that statistician be the disease?
More, that's, we've seen that as the policy thus far.
Mm-hmm. Okay.
But I have to say, in our GI meeting today, I think because all of us are GI,
yeah.
there tends to be a usual, not always, but a GI spin on some of the surgery studies. And the GI committee was supportive of putting them through the GI committee. So I think we kind of use our card, especially when we have a trial that might not be GI, that doesn't get prioritized at the disease site, but we feel that it should be put forth.
Great. Thank you.
Thank you.
So just a couple of thoughts based on our executive officer's comments. Number one is, Flavio and I have been trying to diversify this group. It has been very GI heavy. And, we've done a lot of reaching out to bring in surgeons from melanoma committee, thoracic, GU. So anyone in the room who's not GI that wants to get more involved with the committee, please talk to us, and we are more than enthusiastic to diversify this committee, specifically as it pertains to getting you involved in doing some secondary analysis, because there's a robust set of database that exists within SWOG, just asking to be analyzed and written up. And so if you're a young investigator, young surgeon who wants to write a paper, based on data from a cooperative group, that's a great way to start. And we have, in addition to the couple papers that Lisa showed, we have a couple others that are in press or being written up right now. So we have been, as a group, very active in doing secondary analysis research. I would also advocate for people who are interested in joining the Hope Foundation to nominate yourself. I'm on the Hope board, and all the research that we do within SWOG is really supported by them. And I definitely would also put a plug out to consider making a donation to the Hope Foundation board as well. With that, we're going to move on to our kind of headline speaker for this committee meeting today, and that's Dr. Vern Sondak, who's the chair, Department of Cutaneous Oncology at the Moffitt Cancer Center. He really is a leader, internationally recognized leader in melanoma research, and as a surgeon, and we're honored that he's here to give us a talk on what's new in terms of the management of stage 3 melanoma.
Thank you. Thank you for this invitation, and it is great to see the surgery committee not just vibrant, but contributing so significantly and substantially to the mission of the group with some real impact. And we only had to look at the recent SSO meeting to see the major contributions that SWOG surgeons were making to that meeting. So congratulations to all of you. I am going to talk about stage 3 melanoma today. A lot has changed in melanoma. These are my disclosures. One thing about melanoma is that it is very common. I don't know if everybody realizes just how common it is. And stage 3 melanoma, it's hard sometimes to get an exact feel of how many cases, but about 10 to 15% of newly diagnosed melanoma patients present with stage 3 disease. So with 97,000 invasive cases, we're talking about at least 10,000 newly diagnosed clinical stage 3 at presentation, plus recurrent disease, sentinel node positive cases, et cetera, a substantial number of patients that are in this category. And the number is not going down, it's going up. If nothing changes about our behaviors, the way we protect ourselves from the sun, our tanning bed use, et cetera, and current trends continue, by 2040, melanoma will pass lung cancer, will be the #2 most common malignancy among all Americans and #1 among males. So that's what we have to look forward to if nothing changes in the very, very near future. 2040 is just less than 17 years away. Now, stage 3 melanoma, we've known this for a long time, is an extraordinarily heterogeneous group of patients lumped into one AJCC stage. It can vary from a couple of isolated tumor cells from a very thin primary melanoma to a somewhat larger 1 or 2 millimeter deposit in a sentinel lymph node, to a macroscopically positive, grossly detectable by physical exam or clinical imaging, to unresectable disease that is extensively involving the entire circumference of the limb. All of these things fall under the heading of stage 3 melanoma, and obviously all of them have different prognosis and different needs for treatment. We've known this for many years. This was a seminal paper by Charles Balch from 2010, when they laid out the foundation of the modern AJCC staging system for stage 3 melanoma, dividing melanoma up by micrometastases and macrometastases, and demonstrating that even though the primary was out, the primary's characteristics continued to influence the prognosis of the node positive patient. But what was really striking is the spread of outcomes. For the most favorable group of patients with one sentinel node metastasis from a non-ulcerated tumor, with an 81% 5-year survival, all the way down to a 29% 5-year survival, an absolute reversal. In other words, either 20% alive or 20% dead, depending on the characteristics within the same clinical stage. And as our data has matured, as our staging system has moved on into 2 new iterations since then, we still see much of this diversity, which is not quite as extreme, but you still see anywhere from a 75% to a 43% 10-year survival. So a huge spectrum of potential outcomes. This is based on the number of nodes and whether or not there are those in-transit or intralymphatic metastases that are outside of the lymph node, and based on the amount of tumor in the lymph node. This is the size of the lymph node metastasis here, And you see that for each increment of just a few tenths of a millimeter, we get a worse prognosis. But even with the same number of nodes, we've known that the outcome is worse depending on how we even find the nodes. This was a paper that compared 2 positive sentinel nodes to 1 positive sentinel node and another node found in the non-sentinel nodes at the time of a completion lymph node dissection. And you see that even with 2 nodes, or it could be 3 nodes total, but if they were all sentinel nodes, they were better than the same number of nodes if one of them was non-sentinel. Just how we found them, just how they got into the lymph nodes made a difference in the outcome. What didn't make a difference in the outcome was whether we took them all out in a completion lymph node dissection or we just took out the sentinel nodes and monitored the nodal basin after that. This, of course, is the MSLT2 randomized trial in which patients with a positive sentinel node were randomized to have a node dissection afterward or not to have a node dissection and have their nodal basin followed with serial examinations and ultrasounds. And what we see is that the outcome was exactly identical, and at 10 years, about 70% of these patients alive, all node positive. All of these patients were not treated with any kind of modern adjuvant therapy, and yet we had a 70% 10-year survival. So where are we now? Well, now we're at the point where a 70% 10-year survival doesn't sound that impressive. It sure sounded impressive in the past when we were looking at stage 3 patients with a 20% chance of being alive. Net to say 70% chance, that sounded good, but look what's happened to stage 4 unresectable melanoma. This is one of the most recent updates of the Checkmate 067 randomized trial that took stage 4 unresectable melanoma that had not received any prior treatment and randomized them between ipilimumab, nivolumab, or the combination. If the patients got both, they were over 50%, up close to 60% of patients were alive 5 years after the diagnosis of unresectable metastatic melanoma. This with only systemic therapy, no surgery. So for the first time, we're seeing results in stage 4 melanoma that are almost exceeding what we're doing with surgery in stage 3 melanoma. It's remarkable. And in fact, if they have a BRAF mutation and could get BRAF targeted therapy, some of those numbers are even higher. So where does that leave us today? How do we put all this together into how do we manage stage 3 melanoma and where are the changes coming? So I decided to cover a few topics. We'll see if it gets too late and I can't cover all of them, just let me know. But starting with the occult stage 3 patients, the patients with clinical stage 2 melanoma at presentation, does knowing that they're really in stage 3 because they have a positive sentinel node matter anymore when we're seeing numbers like this with systemic therapy? If we do a sentinel node biopsy, which sentinel node positive patients should have no further therapy like was done in the MSLT2 trial, and which should have systemic adjuvant therapy? And which one should we use if the patient has a BRAF mutation? And then once we get beyond occult disease in the lymph nodes and we present with macroscopic disease in the nodes, is neoadjuvant therapy now the standard of care for patients with clinically node positive melanoma? And if so, what about the patients who show up with an excisional biopsy of their node, who wouldn't qualify for the neoadjuvant therapy trials that SWOG and others are conducting? When we get beyond the nodes and we get into these unresectable in-transit melanoma cases, like I talked about, or even multifocal but potentially resectable with a multitude of surgeries, What's the best first-line management strategy? Should we try to excise everyone? Should we try to inject them intralesional, intraarterial, or systemic therapy? I won't have an opportunity to really answer that question today, but I'll at least pose it for everybody. So let's start right here with clinical stage 2 melanoma. Does knowing the sentinel node status even matter? Why is this a frontline question? Because the last couple of years have seen not one, but 2 positive randomized controlled trials showing that patients with clinical stage 2B and 2C, or T3B and T4 melanomas that are clinically node negative, would benefit from adjuvant immunotherapy. And if they're node positive, they would also benefit from adjuvant immunotherapy. So it's very easy to ask the question, if all these patients with T3B and T4 melanomas are going to receive adjuvant therapy, why do the sentinel node biopsy at all? Why not just go straight from the excision of the primary to immunotherapy? Well, turns out there's quite a few reasons. Sentinel node status and tumor burden still are very important for additional prognostic information that is really substantially important. I've already told you and already shown you some of the data of how heterogeneous the stage 3 patient population is, but I want to show you the difference here between stage 2BC, which is T3B, and T4A is 2B, and T4B is stage 2C, versus the same patients if they have a positive sentinel node, which catapults them all the way to stage 3C or stage 3D if it's multiple positive nodes. And their survival at 10 years goes down from 75 to 80% to 25 to 60%, okay? Just for finding that positive node. That's a pretty big difference. In fact, I try to compensate, but you can't even, these scales are so different, you can't even get the pictures to line up to show how much difference there is between the T4 melanomas and the same melanoma with a positive node. Of course, one of the main reasons we're all here is to do clinical trials and push the outside of the envelope. No one believes that single agent pembrolizumab or nivolumab is as good as it gets in adjuvant therapy. And to do any better, most current clinical trials are depending on the sentinel lymph node status, although we are seeing some industry-sponsored trials that'll say, we'll just take anybody regardless of what their sentinel node status is. But still, the indications for specific adjuvant therapy, for example, adjuvant targeted therapy, requires a positive node. So there's a lot of adjuvant therapy decisions that still are made based on sentinel node status. Nodal recurrences are occurring during the adjuvant therapy if we don't do the sentinel node procedure. We're right in the middle of giving adjuvant therapy, and now the patient has a positive node, a nodal recurrence that wouldn't have occurred if they had not had the if they'd had the sentinel node biopsy procedure. Why? Because the nodal recurrence is happening at a mean of about 9 months after surgery in this T3B, T4 patient population. Adjuvant therapy goes for a year and begins 2 months after, 1 or 2 months after surgery, means 60 to 70% of the potential recurrences could be happening during that adjuvant therapy. And then what? Does it mean the adjuvant therapy didn't work? Did work, worked somewhere else, but it didn't work on the lymph nodes? We don't know the answer to that. Still, the most important reason why we should be doing sentinel node biopsy for these patients, even if they're all going to get adjuvant therapy, is because if the goal for our patients today is to do the fewest node dissections, and I think that's a goal that we are rapidly settling on as an important goal for our stage 3 melanoma patients, the fewest node dissections necessary to have good regional control and a good long-term outcome, we need to do sentinel node biopsy. Why is that? Well, let's do the math. About 30% of these patients will have a positive node. Adjuvant therapy, as we know it today, can decrease that by about a third, assuming every single patient goes on to get adjuvant therapy, whether or not they know they had a positive node. We all know that that is not ever going to be the case, but this assume every one of them gets adjuvant therapy. We could have 20% of those patients requiring a node dissection despite the adjuvant therapy. And as I said, many of those actually while they're on adjuvant therapy. What if they had the sentinel node biopsy then? Well, if with a sentinel node biopsy, we're looking today after adjuvant therapy at about a 5% node positive, node dissection rate. That's combining the patients who had a positive sentinel node and failed in the remaining non-sentinel nodes, and those rare patients who had a false negative sentinel node biopsy. About 5% of the patients who started out with a T3B or T4 melanoma had a sentinel node biopsy and get adjuvant therapy. Today are getting a lymph node dissection. So you're talking about 3-4 times more patients having a node dissection in exchange for not having a sentinel node biopsy. That is not a good trade. So we continue to recommend it, continue to perform it on our patients. Our patients continue to choose to have it. When we do the sentinel node, then which patients can be managed with just surgery and which ones require adjuvant therapy? Said another way, which patients have a good enough outcome that we don't expect that adjuvant therapy would help it. Now, again, I want to review which subsets of patients today have an adjuvant therapy indication for adjuvant immunotherapy or targeted therapy. It's the T3B, T4A, T4B, and the stage 3B, C, and D have an unequivocal indication. The stage 3A patients, which is a T1A, T1B, or T2A primary melanoma and a positive sentinel node, only if it is greater than a millimeter, at least based on the conduct of the trials that led to the FDA approval. Now, here is that stage 3A population, again, with the sentinel node metastasis being at least a millimeter. This is how much value sentinel node, adjuvant therapy adds to the sentinel node biopsy alone. Okay, this graph I picked distant metastasis-free survival, because if we just looked at overall survival, the difference would be probably undetectable today. But assuming it's important to prevent distant metastases, we can take and decrease the number of distant metastases in this stage 3A large tumor burden population from about 70% metastasis free at 4 years to maybe 75, 77%, a small benefit. Obviously, if the sentinel node metastasis is smaller than that, somewhere below that, we're going to lose even this benefit. But where is that cutoff? Is it really 1 millimeter? Probably not. Probably not. This is an aggregate view of all sentinel node positive cases by size. And if you want to look for the 1 millimeter group in there, well, you're going to have to be pretty discerning. It's mixed in with all those other colors. This is the 1 millimeter line. There's nothing about that that indicates it might possibly be a threshold. 2 millimeters is definitely below that, but 0.2 millimeters is just the same as 1 millimeter. So we've always thought that if there was a cutoff, it was most likely well below the threshold of 1 millimeter. And so we participated with Mark Moncrief in England, and a large group of us put together our stage 3 melanoma patients, where we could identify the tumor burden in the sentinel node to see where was the real cutoff. Was there a number where their outcome was just as good, even though they had a positive sentinel node, than if the sentinel node was negative? And you see here that indeed there was at 0.3 millimeters in this study, that out to 5 years, the outcome was just as good as with a node negative patient. But at greater than 0.3 was obviously already worse. Now, it's important to recognize this is a group of patients where recurrences will continue to occur beyond 5 years, but it certainly indicates that a 1 millimeter cutoff is probably beyond where we need to be, is not discriminative enough. So we will offer adjuvant therapy to a node positive patient with a 0.3 or a 0.4 millimeter melanoma in stage 3, and anyone with a stage 3B or stage 3C melanoma, regardless of the size of the nodal metastasis. This is only for the T1 and T2A sentinel node positive patients that we use this size threshold. Now, if the patient has stage 3 melanoma, as soon as we get a positive sentinel node, first thing we ask our pathologist to do is an immunochemical stain for BRAF V600 mutation. Now they do it essentially reflexively, automatically on these even micrometastasis. You can usually do it by immunochemistry. That's not perfect compared to doing it through molecular testing, so we try to follow it up. But if you're talking about a 0.3 millimeter metastasis, that may or may not be possible. You may only get immunochemistry for your information. But we try it on everybody. Every stage 3 patient we think should have a BRAF test. Now, we don't know whether they should get BRAF targeted therapy or adjuvant immunotherapy, at least based on comparative head-to-head data. We know that both of them work. There are some people who say, that's pretty amazing that, and I was one of them that said, BRAF, we think of that when we target it, that sooner or later the melanoma is just going to figure out how to live without the BRAF protein and become resistant. And in very advanced disease, it almost always does. But that's not what happens when we use targeted therapy earlier. So there's a possibility that maybe using targeted therapy is actually better because it's curative in the early stage situation, but it's not curative in the late stages. On the other hand, it always works even in the late stage. You get responses even in late stage disease. So maybe we should be holding on to it. We don't know. We don't have prospective data. We have non-randomized data that compares what the outcomes look like with both BRAF/MEK adjuvant therapy and anti-PD-1 adjuvant therapy. And I think that offers at least a hint, and it at least tells me a general principle that we try to live with. And that is, if you see here, let's see if I can highlight this, whoops, that the patients who got anti-PD-1 adjuvant therapy seem to have more drop-off in the first few months than the patients who got the BRAF targeted therapy. In other words, early recurrences are less frequent with BRAF targeted therapy. On the other hand, out later, maybe there's more of a plateau with immunotherapy. It certainly makes sense. So if I have a patient that I think is at high risk for an early relapse, multiple positive nodes, other poor prognostic factors, and they're BRAF mutant, then I want to use BRAF targeted therapy, avoid an early relapse, kick the can down the road as long as possible. If it's that 0.3 millimeter melanoma in a stage 3A patient who we're having to look at 5 years and beyond to see where the impact of the disease is, then it probably makes sense to use immunotherapy there. But we just don't know. And there's huge differences in the kinds of toxicity we're talking about. It's a major unanswered question. Now let's turn to the clinical macroscopic stage 3 patients. Talk a little bit about neoadjuvant therapy. I've talked about it to this group before. It's quite familiar with to many of you, but I'll summarize it quickly. The problem with adjuvant therapy is we give it to everybody. We help a few people. We don't even know who those people are. We have, this is the EORTC trial of pembrolizumab in stage 3 melanoma. This is recurrence-free survival. So everyone up here recurred despite receiving pembrolizumab. Everyone down here never recurred despite not having any therapy. So treatment would only be associated with toxicity without benefit. And only this small percentage in the middle derive any benefit, but we don't know who they are. We don't know if they derived the benefit or if they would have just been cured by surgery alone. In contrast, neoadjuvant therapy has a lot of potential advantages and some potential disadvantages. The disadvantages are pretty obvious. Progression could lead a resectable tumor to become unresectable. Toxicity could lead a patient who was all set to have surgery to not be able to have surgery or to have surgery with a higher risk situation. On the other hand, we can assess the response of treatment. We can identify those patients with rapidly progressive treatment unresponsive disease who wouldn't have benefited from surgery anyway. There were a lot of potential theoretical advantages. Where did they? Everyone gets a year of pembrolizumab. Everyone gets the same operation for their stage 3 melanoma, but half the patients get 3 doses of the pembrolizumab before surgery. And let's see what happens, not just to their melanoma, but also to side effects, to toxicity, to resectability of their disease. We want to know everything about these 2 groups. How many of them had progression or toxicity that rendered them unable to receive surgery? How many were unable to begin their adjuvant therapy for any reason, including unresectability, toxicity, complications? How many had a recurrence? How many died? Okay. We had to pick a date in which to start the adjuvant therapy to make it fair and avoid somebody just delaying and delaying and delaying. And we picked 84 days as our target. What we found was that among the patients randomized to neoadjuvant therapy, 14, which out of 150 something, 151, I believe, or 159, didn't get their planned surgery. 1 because of toxicity, 12 because of disease progression, 1 because of another unrelated illness. On the adjuvant arm, all but 1 person got their surgery, and that one was because of problem getting their surgery scheduled. However, when you talk about the completeness of the surgery, which patients had an R0 versus an R1 or R2 margin positive resection, after 3 doses of neoadjuvant therapy, only 6% of the patients who had surgery had a margin positive resection, whereas it was 14% of patients. Every one of these patients was certified by a surgeon that they were ready to go and we would get it all out. And every one of them would say, if you wait 3 months and it's unresectable, it's your fault, not my fault. But in fact, it was the opposite. We couldn't tell. In over 1 case in 6, we couldn't tell. We thought they would be resectable, and really they were not. Okay. In all, 96% of patients got on neoadjuvant therapy, got the operation they were planned to get versus 97% in adjuvant therapy. The bottom line was it didn't lose really anything compared to going straight into surgery to give the patient 3 doses up front. And that's depicted here. You see that they both start at the same point when they get ready to get adjuvant therapy after surgery. Yes, was there a question?
Oh, no, sorry, we were just whispering because there's that drop in the
Yes.
survival curve. Probably was when you first get the surgery.
This is day 84 here, okay? And so all of those events before surgery were normalized to day 84, okay? So that it wouldn't artificially bias between the two groups. So yes, so it was actually 19 patients on the adjuvant arm had an issue before the start of adjuvant therapy 84 days after surgery, and 20 patients on the neoadjuvant arm had toxicity or progression before the start of adjuvant therapy. Essentially a toss-up, and then what happened is obviously a big, big difference from that point on, because after they started adjuvant therapy, 50 patients on this study have experienced a recurrence, 9 or 51, excuse me, 9 on the neoadjuvant arm, 44 on the adjuvant arm, a huge difference, okay? And the time to recurrence wasn't any different, but the number of recurrences. And while it's early, we're already seeing fewer deaths on the neoadjuvant arm than on the adjuvant arm. So dramatic difference. The only alteration between the two arms is just the timing of 3 doses of drug, a very, very powerful demonstration of how valuable neoadjuvant therapy can be. And again, everyone got all the same treatment. Now, this is a different study being conducted in Europe and Australia called the Nadina trial. It doesn't show up very well. It's designed to be similar to SWOG 1801, but not identical. Instead of asking everyone to be exactly the same except for a few doses, they're saying, let's compare the best neoadjuvant strategy we have to standard adjuvant therapy. So this group is a year of adjuvant anti-PD-1 after a full node dissection, just like the control arm on S1801. But this group gets 2 doses of ipi-nivo instead of 3 doses of just plain anti-PD-1, and then has a node dissection, and then continues on therapy only if they had residual viable tumor. So best neoadjuvant strategy against standard adjuvant strategy, a little more complicated study design, but when this study is available, it will further add to our knowledge base. We are not ready to even go beyond that point and say, why do we have to keep treating everybody the same surgically if neoadjuvant therapy is doing so well? This is the Prado trial, just recently reported, an excellent commentary about this from Mark Ferries in this week's Annals of Surgical Oncology. Here they gave what we consider the best current neoadjuvant therapy, 2 doses of ipi-nivo using a low dose of ipi and a standard dose of nivolumab, and then doing what they termed an index node resection. They picked a node and said, this is the node, either the node that was biopsied and had positive tumor, or the largest node if several nodes had tumor in it, put a marker in there, and only took out that node after 2 cycles of therapy. And depending on how well the tumor had been killed in that lymph node, that determined what was done next. And if it was a major pathologic response, complete resolution, or less than 10% viable tumor, no further treatment, no more surgery, no more immunotherapy, just a removal of 1 lymph node. If there was a partial response, they had a therapeutic lymph node plus or minus additional adjuvant therapy, depending on the exact results. We've begun using this quite a bit. This is the marker that they used, the small magnetic seed placed into the lymph node and found with a magnetic detector. We use a SAVI clip, a radar reflecting clip. This is that radar reflecting clip you see in this specimen radiograph. All these other things, those are medium titanium clips that we routinely use in surgery. So it gives you an idea of the size of the clip, just a little bit smaller than a standard medium titanium clip, and yet easily found even in a specimen filled with other clips. And if there is little or no viable tumor in that lymph node, we're doing nothing else, and those patients are doing very well. There are other ways we can adaptively change the treatment based on the response to neoadjuvant therapy. This is a trial ongoing at our institution in which patients get targeted therapy. BRAF mutant melanoma patients get 6 months of upfront therapy before surgery, and then are randomized based on their outcome, either no further therapy, continue adjuvant therapy, switch treatments, depending on the pathologic response. So I think we're still learning just how much can we learn, how much can we use the response to the first preoperative doses of treatment to modify the treatment. Now, what about though the patients where we can't learn from their operation because the surgeon took out the lymph node as the diagnostic procedure? If we could get a message across to all of our general surgeons, it's any patient with a history of melanoma and a palpable node, an excisional biopsy should be considered contraindicated until they've had at least one, and I believe at least 2 attempts at a percutaneous diagnosis. Okay, just like we tried to educate people, don't shell out a sarcoma, try to do a core biopsy, and you can only do an open biopsy if you've tried 2 core needle biopsies. That should be a message about nodal metastasis in a patient with a history of melanoma. There's still going to be unknown primary melanomas. And so frankly, it's anybody with an enlarged node should probably have a needle biopsy first, but it could be a lymphoma. Well, we can diagnose lymphoma very easily on a core needle biopsy today. There's no real justification for removing a lymph node as the initial diagnostic procedure, but it still happens all the time. And when it does, we lose that ability to assess the pathology, but we also lose the possibility that that nidus of tumor can be exposed to the immunotherapy and activate all the T cells that we think is the reason why the immunotherapy was so much better in SC1801 than giving it all after surgery. But what if that's not the reason? What if the reason is the patients after surgery have an immunosuppressed state of some sort? Yeah, whatever, sure they do for a little while, but what could that really mean? Well, I don't know, but I have a suspicion that that's a big part of the issue. So my colleague John Zager and others put a study together looking at the timing of postoperative adjuvant therapy. This is all postoperative therapy, no neoadjuvant therapy. Everyone had a complete node dissection or a sentinel node biopsy. And they looked at 6 weeks, 12 weeks, or beyond 12 weeks for starting the adjuvant therapy. You would think the earlier you started adjuvant therapy, the better. In fact, it was the exact opposite. The later they started the adjuvant therapy, the better, even accounting for other prognostic factors. And that was true for relapse-free survival and overall survival. And this isn't prospective trial data, isn't it? Weren't randomized to get adjuvant therapy at 4 weeks versus 12 weeks, but it's very provocative and stands up on a multivariate analysis to suggest that, yes, there actually might be a lingering post-operative immunosuppressed state that is part of the physiology of wound healing. There are neoantigens in the wounded environment that we don't want the immune system to respond to, and that may be contributing to why preoperative immunotherapy would be better. All right, well, I'm just about out of time. I'll just say that this remains a very, very important question when we get to the unresectable or the borderline resectable stage 3 melanomas, whether we should try to resect, whether we should do intralesional or intraarterial therapy, or whether we should go straight to systemic therapy. Our medical oncology colleagues consider this just not a question. If these patients are referred to the medical oncologist, they get systemic therapy. You would think they have a low tumor burden, they would do really well. They don't do particularly any better than we would have expected from stage 4 disease. That's pretty good, obviously, as I showed you, but it's not better. There's still an opportunity to use intralesional and intraarterial therapy early on and potentially spare some patients the need for systemic therapy. But where we really need to figure out what to do is when this in-transit disease shows up after adjuvant therapy and the patient is no longer treatment naive and we don't have the full spectrum of systemic therapy available to deliver. I think we're still going to see a role for excision, intralesional therapy, and intraarterial therapy with limb infusion for many, many years to come. So I'm going to conclude by saying sentinel node biopsy and adjuvant therapy remain important for the management of clinically occult stage 3 melanoma. Neoadjuvant therapy is now, in my opinion, the absolute standard of care treatment for clinically detectable stage 3 melanoma, and we have to approach it right from the stage of, gee, why does that person have an enlarged lymph node, as if that is the case. So needle biopsy techniques have to be routinely employed to establish a diagnosis of nodal metastasis and facilitate neoadjuvant therapy. And there's still an awful lot we have to learn about the treatment of advanced stage 3 disease. So plenty of work for all of us to do. Thank you again for this invitation and for all you're doing in the surgery committee, and I'll be happy to answer any other questions.
Thank you very much, Dr. Sondak. That was a fantastic, review with, really what's sort of enviable data that we now have prospectively in melanoma. So I wish we had some of this in some of the other disease sites. Any questions from the floor or anybody from online? So I assume that one of the open questions now is, should neoadjuvant therapy be extended to a longer duration? So I wonder about thoughts on that.
And did you mind repeating the question to Mike so that people online can hear your question? That's a great, I was going to actually ask the same question.
My question was, I assume one of the open questions now is the question of extending the duration of neoadjuvant therapy and what the thoughts in the field are along those lines.
So it's quite interesting. I think all of us agree as the data continues to come in that the more patients get a pathologic complete response to treatment, the more good things happen. The better they do, the less surgery they need, the less total treatment they need. Yet among our medical colleagues, there's actually a great reluctance to extend the treatment. Why? They're scared the surgeons will rebel and say, you can't do that. So our medical oncology colleagues, some of them have internalized that so much that they say, I know I can get away with 6 weeks. I don't want to push it and lose these patients. We've got to help them understand, no, that's not the issue. If more is better, then we should be doing more. If it's not necessary, that's fine. But at Moffitt, our approach has been to try to extend the preoperative phase and minimize or eliminate the postoperative phase. If you do that, there's a risk that you're going to run into toxicity. There's a risk that you're going to run into disease progression. But these should not be patients who are just sent off into the community and vanish and come back eventually. These have to be watched closely. I would say that's actually our single biggest problem at a referral center like Moffitt, is that people say, can I go back and have my adjuvant therapy in the panhandle? And we say, yes, as long as you come back every 2 cycles and get evaluated, and we, that somebody doesn't say, gee, this doesn't seem to be working, I'll try this and I'll try that. So that remains the biggest challenge. But I absolutely agree that that we have to weigh the possibility that extending treatment will improve outcomes. And that's what our targeted therapy trial is actually intending to do.
So just kind of bouncing off of Andy's question, in the 1801 study, the neoadjuvant arm, that must have been a very heterogeneous group in terms of outcomes.
Yes.
And so is there any data in terms of response to the 3 doses and how they did? I mean, you mentioned that, PathCR or, near total response did better than, was that seen in 1801?
So that's exactly the analysis that's ongoing right now. The challenge of 1801 has been that, of course, being a cooperative group study, every one of those surgeries was operated on, looked at by the local pathologist. Sometimes they said there's no tumor. Sometimes they said there's some tumor. Rarely did they grade it and analyze it the way we would do that at Moffitt, where our pathologists have been studying neoadjuvant therapy basically since its inception. So currently, all those pathology slides are being reviewed centrally so that we can have a more conclusive statement of what a pathologic complete response means. But I think that's always going to be a little bit of a limitation of the 1801 data. And of course, with only a single agent anti-PD-1, you're talking about a 20-25% PathCR rate, whereas with combination therapy, we're looking at 50 to 60% PathCRs, or with desmoplastic melanoma, we were at 55% PathCR. So that study, 1801, is never going to be really conclusive for that, but it's the next level of data analysis that has to take place.
Sounds like a great opportunity for a secondary analysis, like Dr. Kanslick mentioned.
And
Dr. Mayo?
Glow already presented some of the surgical data at the SSO plenary session this past March.
Sky Mayo, OHSU. Great to hear this talk. And Dale Hahn was one of Flavio and I's partners,
Yes.
and I know close to you as well. And good to see this work, I think, moving on. And I would like to see more work within our surgical group for melanoma specifically. I think I have 2 questions for you. One is, I can look on any OR schedule in any hospital on any day, and I can find someone doing a node biopsy. This exists, and it's not just general surgeons.
Yeah.
It's actually also driven by medical oncologists who are still feeling in some ways that you can't diagnose a sarcoma from a core needle biopsy. We need to do incisional biopsies. So there's an education piece that we have to be involved in. And I think the second is this, where we're going for, we see melanoma, and I think it's gonna get harder and harder to be able to give adjuvant treatment to any disease just thinking it's going to work when we don't have anything to follow, without any like molecular residual disease marker or MRD, whatever. So the idea of testing it in situ, seeing if it works, and then being able to follow it, I think is going to be, is a prescient approach to all cancers. So that's a thought.
I agree with you.
Any other questions? Well, thank you very much. That was a
Thank you.
fantastic lecture.
Thank you. All right, so now we'll get to our trials and projects and development. First one is going to be Dr. Samir Patel, Associate Professor of Surgery from the University of Cincinnati. who's going to update us on the high-grade appendiceal cancer trial concept.
Broke it. So this concept was briefly presented during the closed GI meeting. So some of you probably have heard a snippet of this earlier today. Hopefully we'll have a more of a discussion.
Yeah, slightly
this
updated
presentation.
version. Good afternoon, everyone. And we'll try not to go through too much more of the background and things, but hopefully provide more of a refined kind of concept that we kind of came out from this morning. So I think as everyone can appreciate, appendix adenocarcinoma, very rare and heterogeneous disease. Oftentimes in the setting of when these patients present with peritoneal carcinomatosis, really the mainstay of treatment for a chance for long-term prognostic improvement is really CRS and HIPEC. The problem is really the treatment for this disease is all over the place. And particularly for those patients with high-grade cancer, we treat them much like we do patients with metastatic colorectal cancer with peritoneal-only carcinomatosis. And that really revolves around using CRS HIPEC in conjunction with chemotherapy. Oftentimes it's either in the perioperative setting, so before and after HIPEC, or just in the complete total neoadjuvant setting. The problem is over the last few years, as we really dove deep into the molecular basis of appendix cancer, we found it's nowhere similar to really colorectal cancer, even though we are using the same chemotherapy regimens. And this is really no matter how you break it down. If you compare it to right-sided colon cancers, left-sided colon cancers, and even within the category of appendix adenocarcinomas, the low-grade and the high-grade lesions have very different molecular profiles. And so, the general concept and idea is that systemic therapy should work to improve survival in patients that have high-grade appendix cancer. But really, how much benefit does neoadjuvant therapy actually provide? And this is really coming into question with several trials, two of which have come out in the last several years. The first one kind of came out from the HIPEC Collaborative, which is a group of 12 HIPEC centers around the country. And they looked at patients that underwent CRS HIPEC, and they compared the group that underwent neoadjuvant therapy to those that went HIPEC alone. And essentially, they found that the group that underwent neoadjuvant therapy actually had worse overall as well as recurrence-free survival. The problem with this study was that it was a very heterogeneous group because it looked at low-grade tumors in addition to high-grade. And so the Wake Forest group, just not even a year ago, presented their data where they looked at the same question, but really only focused in on what they defined as high-grade adenocarcinomas. And they similarly found that the group that underwent neoadjuvant therapy actually had a worse overall survival. So this really called into question, how much benefit does neoadjuvant therapy actually provide in these patients that have appendix adenocarcinoma? Now, both of these studies had a PCI score, a peritoneal carcinomatosis index of about 16, which is a moderate volume of disease, meaning that even in the setting of surgery alone, the chance of achieving complete cytoreduction was very high. And so this is not patients that had a PCIs of 20, 25, 30, a very, very high burden, but ones with a moderate volume of disease. And so the objective of this concept was really to compare the outcomes of using a perioperative versus a surgery first approach for patients that had high-grade appendix adenocarcinoma with quote unquote limited peritoneal carcinomatosis. So this morning we had discussed doing a phase 2 and phase 3 trial, but after discussion, we came back to our original idea of doing a pick the winner design. So high-grade adenocarcinoma we defined as having moderately poorly differentiated adeno with or without signet ring cells. We're also including signet ring cell adenocarcinoma. These patients cannot have had prior CRS or HIPEC, have evidence of visceral extraperitoneal disease, and on imaging have evidence of a very high PCI burden. And we choose a cutoff of 15 based on just existing data. So after enrollment, these patients would all undergo diagnostic laparoscopy to assess what the PCI burden is. Now, we know it's not going to be a complete, accurate reflection of PCI because it oftentimes underestimates it, but we chose a cutoff of 15 as it gives us a good sense of, is it possible to achieve complete cytoreduction or not? If it is, those patients are then randomized to either CRS or HIPEC alone. And in this idea, if we choose kind of a pick the winner, we would use our baseline historical control of basically a 40% recurrence-free survival. So one arm would receive CRS and HIPEC, the other would receive a perioperative approach. So they receive 3 months of chemotherapy. And again, from discussion this morning, we have chosen to use more of a broad-based chemo regimen, so either FOLFOX, FOLFIRI, or Zealox. If after 3 months there was imaging evidence of either stable disease or at least no obvious visceral or extraperitoneal metastases, they would then go on CRS and HIPEC. Our primary endpoint would be 18-month recurrence-free survival, and I'll get into the statistics a little bit more. Our secondary endpoints are many, but of the few, we talked about complete cell reduction rate, overall survival, peritoneal recurrence-free survival, and accrual rates. We had also built in extensive correlatives as well as quality of life. A key tenet to this was to have central pathologic as well as radiographic review, because we know that is really an Achilles heel for accurately diagnosing appendix cancer. And if we get into the kind of statistics, and if we use our baseline based on existing data, if we choose a 40% 18th month recurrence-free, peritoneal-free recurrence, and we chose an alternative hypothesis of about 60%, meaning a 20% absolute increase, based on a kind of pick the winner design, we would need a sample size of anywhere from about 20 to about 40, depending on if we chose 90% or 80% power. This was, if we had considered a phase 2-3 design, we would be up into the at least 150 patients or so. And so this is a much more reasonable patient number to actually even complete the trial, which I know is a big concern, particularly since this is going to be the first one we're doing in this fashion. And just to highlight, again, there really are no national randomized control trials in this field or in this disease type. And so whatever data comes out of this will be extremely helpful. We'll set the stage for the standard of care and how we treat these patients. It'll be the baseline for future studies where we can build off of. We'll get numerable quantity of data by just knowing feasibility, dropout rates. How are we going to assess quality control, not just surgically, but radiographically as well as pathologically? We'll have quality of life, correlative data, numerous publications hopefully will come from this. And then really we hope that SWOG will be kind of the cooperative group that's going to really pioneer and lead these high CRS HIPEC studies. And so I'll end back with the modified schema that we now have that hopefully we'll be able to continue to push forward, and happy to take any questions.
Dr. Sohal. Dr. Sohal.
Maybe I lost thread this morning. Did we decide that the chemo should be dealer's choice?
I guess that will be to be determined, but from this morning, it seemed like there was a lot of pushback in the FOLFOXIRI component to it, as opposed to doing it all. And again, we are.
So let's get Dr. Lowy's comment on FOLFOXIRI, because he has experience with that at UCSD. And even though it's not published, it's still important experience.
Yeah, I mean, I would just say that our experience is that it's a more active regimen, and actually that irinotecan tends to be one of the more active agents in this disease, as opposed to oxaliplatin in general. So we've seen by far the most robust responses in neoadjuvant treatment with FOLFOXIRI as opposed to doublet chemotherapy. Realize obviously it's a small experience, but I think particularly in the neoadjuvant space, these days, certainly when we're treating colon cancer or obviously pancreas cancer, we're using triplet chemotherapies to try to get patients to the operating room, et cetera. And the point here, obviously, especially in the neoadjuvant is to make sure that you can do a complete cytoreduction. That's really the only chance for long-term survivorship. So that was my thought. I understand the pushback, although a little bit, but not so much, given the paucity of data on really any of these regimens. And it's hard to argue that the triplet regimens aren't more active in every single setting that they've been tried in GI oncology. So,
and the point that you made, which I wanted to say for the audience, which is a good one, is that if these patients are going to withstand CRS HIPEC, then that kind of tells you about the performance status. And so I do think that's a good point.
And the adjuvant 6 months is going to be the same chemo, whatever the neoadjuvant is.
We really didn't focus too much on that this morning. A little bit of the discussion was about, should we leave it at dealer's choice, depending on their performance status after, or will we mandate the same regimen, particularly if we talked about a 3-drug regimen?
And the other thing is we are moving more and more toward 3 months of adjuvant and colorectal, for example. So what about 3 months of FOLFOXIRI, hit them hard, take them to surgery, end of story, or the opposite in the other arm? Because beyond 3 months of FOLFOXIRI is hard anyway. And you get an answer you a little quicker.
So you're saying
just 3 months of chemo. Why 6?
What about the second arm?
The adjuvant arm.
3 months
of
FOLFOXIRI, same.
No.
I mean, that we cannot introduce that second variable.
Right, that's the point I was gonna make. You can't introduce another variable there.
Well, let me ask a question. I mean, are we comparing the chemotherapy here, or are we comparing the strategy?
Strategy, right?
Strategy is the
Strategy.
primary compared, yeah.
Right. So, I mean, does it, I mean, again, I don't mean to trivialize it, but does it matter if you're switching FOLFOXIRI to FOLFOX?
But that's why you have to keep everything else standard.
Everything
because
else has to be the same.
Okay.
If you have another variable, then you've added another, confounding variable that you don't know if it's a strategy or the chemo.
But I think if you keep it to investigator, right, as opposed to mandating different ones.
It'll become a very, especially if you are doing the pick the winner design and 20 patients, if people have given 3 different chemos,
Yeah.
Yeah, I agree. If you're truly looking at strategy, everything else has to be standardized. Otherwise, you don't know what the results mean.
Yeah, I'll make the other argument that the only novel thing that would be included here would be using a triplet regimen.
Yeah.
Because if you think about it, you're basing your hypothesis on all this, large amount of retrospective data, and you're looking for an improvement. Well, what's the improvement supposed to be based on? I mean, maybe, operating up front, but even operating up front, I'm not sure if that reached that bar in all of those studies. So, you're looking, I mean, were we at 60% in
pre-op? Yeah,
in surgery up front?
Yeah,
Okay.
they reached, and that was a reason why, and
Okay.
just in large part because of
I
it.
didn't think it was
The hope
quite
would
that
be,
high.
like you said, if the tribe data for metastatic colorectal, again, different
Right.
patient
But
population.
I
they
would
got-
argue when you go from retrospective, obviously, to prospective, you're gonna lose.
Mhm.
There's going to be selection bias accounted for here. That's going to
Yep.
make your results worse. So,
Mhm.
So do we know if there's buy-in?
I just
for that?
think so. So my argument is use the best systemic regimen, the most active one that we have. I think the duration is, I mean, I think you guys can. Usually, medical oncologists in stage 4 disease get antsy about shortening the regimen. The shorter regimen's really only in stage 3 colon cancer. Right. So that would kind of be, I just thought, that folks would be uneasy with that.
And
I
what
mean,
was,
you could do 3 months of FOLFOXIRI and then 3 months of doublet. If people are worried about tolerance, then, you can do that.
But then even in,
That would be kind of a compromise.
but then the adjuvant arm,
Yeah,
are you
we'd
saying?
have
Well,
to-
the same thing.
Three-
You just-
3
you
months and
start with
3
three
months.
FOLFOXIRI, then step down, so I don't, that's for the medical oncologist to think where their comfort zone is.
yeah. because
What was the difference
tolerability.
in sample size between pick the winner and?
It was like about 150 patients realistically, if dropout rate versus, sub 50, or probably realistically 50 with a
Yeah.
dropout rate. So it's magnitudes and years of patient accrual.
But back to Devindra's point, so how many centers are actually using FOLFOXIRI for this?
At least 5 that I've personally reached out to.
it's not a hard sell. I mean, I'd be fine giving FOLFOXIRI to a patient for 3 months and then take them to the OR.
I think the compromise is 3 and 3.
Yeah, and I think
Yeah.
the point that was made is, I don't know if it was, I heard from somebody say, yes, you can design it that way. And then, yeah, if they can't tolerate it, they'll have dose reductions, they'll
Yeah.
take out an agent. I think you can still do the intent to treat.
Yeah, that becomes part of the entire answer
Yeah.
anyway.
And I do think the pick the winner design is the way to go. There's no way you're going to accrue 140 patients.
Yeah.
There's just in high grade, it's going to be a steep hill to climb.
Yeah, so it sounds like an adjuvant setting leading a doublet regimen as opposed to FOLFOXIRI, and shortening the adjuvant.
Well, the adjuvant's got to be FOLFOXIRI and FOLFOX 3 and 3. Because if you're giving neoadjuvant FOLFOXIRI, then they have to see the same drugs.
Right.
And then I think just pick the winner design for sure.
Mhm.
The other will be a very steep hill to climb.
I don't
Good. So next is stats, right?
believe so.
Sarah? No pressure. Okay, any other questions? All right, thank you.
All right, appreciate it.
All right, well, next up, someone who needs no introduction to this audience, but Dr. Devendra Sohal, professor of medicine, University of Cincinnati. We got the 1-2 punch here. TNT with novel agents for resectable, borderline resectable pancreatic cancer.
Thank you very much for inviting me to a surgical party.
You're kind of a surgeon. You hang out with surgeons. So.
Yes.
We are all oncologists, just different modalities.
Sure. Is this shared? How do we?
It should pop up as soon as yeah, there you go.
Excellent. Thank you. This is a study of total neoadjuvant therapy with novel agents for resectable and borderline resectable pancreatic cancer. The background is this was 1505. This was the first study testing neoadjuvant chemotherapy in the cooperative group setting for resectable pancreatic cancer. This was a perioperative approach, FOLFIRINOX versus gemcitabine nab-paclitaxel. It was also a pick the winner design. And these were the take-home points. The overall survival was just shy of 2 years, which is still what we see in all comers in resectable pancreatic cancer. The two arms of chemotherapy were essentially identical, no differences there. A big difference was seen in the tolerability of chemotherapy, neoadjuvant 85%, adjuvant only 45%, and even the adjuvant FOLFIRINOX pivotal study with surgery followed by 6 months of FOLFIRINOX, it was actually the same answer. Only 42% of patients got total completion of adjuvant therapy. So less than half get it post-op. So we took home the lessons that we should give total neoadjuvant therapy, basically plan to give them everything up front, whatever they can take, and add novel agents. We've hit a ceiling with chemotherapy. We're not making any improvement with more cytotoxic drugs. And that led to this design, which is TNT, total neoadjuvant therapy with novel agents. We picked a FOLFIRINOX backbone. Why did we pick FOLFIRINOX despite 1505 showing identical results? Because of the totality of data in pancreatic cancer. Adjuvant FOLFIRINOX was successful, adjuvant gem-nab-paclitaxel was not. In metastatic disease, FOLFIRINOX smells better than gem-nab-paclitaxel, and now the NALIRIFOX data presented at ASCO GI in the metastatic disease clearly showed that the triplet is better than the doublet. So we picked, obviously in the curative setting, the most aggressive chemotherapy regimen as the backbone. We've added experimental agents. Nadunolimab is an IL-1 RAP antibody. It is basically an antibody that affects the myeloid system. And that's what we're trying to go for here, the myeloid system. The lymphoid system has not worked. PD-1 has failed miserably in pancreatic cancer. Other approaches targeting the lymphocyte system have not worked. And the third arm, which is the second experimental arm, is FOLFIRINOX plus cemiplimab, PD-1, plus motixafortide. Why PD-1 here? I'll go over some more data because that it does act in conjunction with CXCR4, which modulates the myeloid axis. This is a randomized phase 2 design, resectable and borderline. The Pancreas Task Force review actually supported resectable and borderline, so that was a good green light from them. The primary outcome is going to be event-free survival, a hazard ratio of slightly less than, in fact, more aggressive than 0.6, which CTEP likes to see. 12.6 months to 21.4 months. We'll need 72 patients per arm, so about a 210, 220 patient study total. We are going to build in real-time baseline scan reviews because we learned from 1505 a lot of beyond resectable disease was enrolled in that study. So here we will have a 5-day turnaround. Scans will be submitted. A central radiologist will review them and make sure they indeed have resectable or metastatic or borderline resectable disease and nothing beyond that. And we'll collect blood and tissue at different time points. Tissue not at baseline given the SWOG structure, but we will certainly collect surgical tissue. And we'll do safety analysis at 14 patients to make sure that nothing bad is happening in the experimental arms. quick overviews. This is IL-1 RAP. It affects the IL-1 alpha and beta arms both. A gem-nab-paclitaxel study was conducted with the addition of this antibody, and a overall response rate of 33% and a median overall survival of 12.7 months was seen with this combination. If you look at the historical control of 8.7 months, this was certainly promising, and for FOLFIRINOX, safety data are ongoing in a European trial. And this is Venu's work out of Seattle, and he has shown that CXCR4 impinging on the myeloid axis inhibits the immunosuppressive action, and that leads to PD-1 working better. And a keynote comparison study was performed using 5-FU nanoliposomal irinotecan, CXCR4, and PD-1, and it showed a median overall survival of 6.5 months, which was again promising compared to 4.7 months historical controls. Again, this is honestly a bit of a leap of faith, but the struggle is that if you wait for results in stage 4 disease, the drug is either a bust, and if it is going to be successful, the companies are going to do their own trials. We have 3 companies lined up for this now. It's ready to go to SWOG exec, and we hope you support it. Thank you.
Thank you. So first question is, another lesson we learned from 1505 was real-time radiology review. And Dr. Knopp, who I'm happy to say is now also at the University of Cincinnati, we're taking over, is here. Can we comment on whether we have IROC involved in terms of preoperative image review to make sure that we're not enrolling ineligible patients? As we saw, I think 40 at interim analysis, 40 patients were ineligible in 1505.
Yes, certainly that's built in with your support. I mean, we're going to have them turned around in 5 business days.
I mean, we currently run the Alliance trial this way with Central Weaker, and we are having more and more portfolio. So basically our policy is that we can commit to 72 hours.
Awesome, thank you.
A question on the of chemotherapy, Devendra, because are we trying to match sort of, because it can depend a little bit of what happens to the Alliance trial, right? Are you using the same, maybe I missed it, 6 months. So that's different than what they're doing in the Alliance trial.
Yes, so what we have, as I said, what we are going for is give everything up front. Practically speaking, we are going to build in very liberal dose modification. Most patients take 4.5 months and they get tired of it. And that's when we will stop. We're not going to drag them out on single agent 5-fluorouracil and make them too frail. So as soon as they go below 70% dose density, we're going to stop and take them to surgery.
So another question that a lot of people have asked me is 6 months of therapy up front, toxicity to the liver, from oxaliplatinum, irinotecan, will that affect ability to do surgery? What do people think in here? 6 months okay in terms of doing a pancreatic duodenectomy? Okay.
Yeah, I think it's not as big of a deal if you're doing a liver resection. I mean, although if you start seeing a spleen getting big and the platelets dropping, you may want to consider, as Devendra said, kind of backing off a bit. And then I'm assuming we'll track CA19-9s and look at all that stuff too. I think
yes, we'll build that in. We're going to collect blood and at 5 time points and save it. We could go back and look at things like immune profiling, ctDNA, etc.
Yeah, I do think there should be a surgical checklist. We didn't have a surgical checklist for 1505, and I think we lost an opportunity. And there's lots of reasons why that was. We're just trying to get the study open. But I think this time around, we should have a surgical checklist. So we have structured data that we're collecting to ask specific secondary analysis questions.
Sure.
Yep.
Sure. Thank you.
Thanks. Our next presentation is from Jonathan Sham, Assistant Professor of Surgery, University of Washington. Again, we heard briefly the concept in our closed GI session, lanaritide for the prevention of perioperative pancreatic fistula. This study is being developed through the cancer the Cancer Prevention Palliative Care Committee, as well as a surgical committee.
Excellent. Thanks so much, Dr. Ma, Dr. Roca, for the ability to get a little bit more depth in this group, because I have well, we're close to the finish line. We have a couple of just, I'll say, lingering questions I'd like to run by the group. Yeah, this is our concept looking at the drug lanreotide in order to reduce pancreatic fistula in the postoperative setting. This is really kind of old data for this group here, but just for any non-surgeons in the room, pancreatic fistula is kind of the defining complication after pancreatectomy, doubles healthcare costs, decreased quality of life, delays chemotherapy, and is even associated with decreased overall survival. After a year of back and forth with the drug company and then another drug company, we finally have agreement from them to supply drug for the trial. And this is the schema. Very straightforward. 274 patients, 246 are going to be analyzed, randomized, and then again, single preoperative dose of lanreotide, 120 milligrams, which is the standard dose, and then distal pancreatectomy and usual care for the center. Primary outcome is clinically relevant postoperative pancreatic fistula, which is grade BC for the ISGPS rating. Secondary outcomes are biochemical leak, hospital length of stay, and then quality of life metrics at 14 and 60 days. That timeline was selected based off of work out of MSK, where they use those instruments in this setting at those time points. And then exploratory outcomes, time initiation of chemotherapy and hospital readmission rates. We are kind of building in and planning for a cost effectiveness and financial toxicity analysis, because that's, I think, of interest to this group, as well as some translational studies looking at actually tissue and serum postoperatively. Here's the eligibility criteria, really broad, and we try to keep it that way to improve our feasibility. Essentially 60 days planned distal panc. We're trying to get NET, PDAC, malignant appearing cysts, essentially almost everything except for pancreatitis is the goal. And that's why we included this pancreas lesion with malignant potential, so to include cystic disease. And we are asking that surgeons leave a drain in. I know this was a bit debated at this setting at one of the last meetings. We recently sent out a survey, and about 90% of the survey responds are routinely leaving drains. So we don't think it's going to be a big barrier to accrual. And then, of course, exclusion criteria: if you're on a somatostatin analog for some other reason, radiation therapy, pancreatitis, malabsorption syndromes. And as importantly, this was added by Paul Karnikolas. He's part of the HPVA clinical trials mentorship program. He's my assigned mentor there. He said we should add multivisceral resection, because that obviously is a marker for increased complexity, blood loss, et cetera. It might be hard to control for. Here's the feasibility and statistics. I got into this a little bit at the GI committee, but essentially, this is the estimated effect size. We're being very conservative. We've lowered the estimated rate in the non-treatment arm and raised the estimated rate in the treatment arm, and we came out to 246 patients. With a 10% dropout rate, there's 274 total. And again, as I mentioned previously, really broad inclusion criteria, I hope will help this feasibility. In the phase 2 trial, 90% of patients that we saw met inclusion criteria, with the biggest reason being they didn't speak English. That was the exclusion criteria. And so we're obviously rectified that for the phase 3. So hopefully that number will go up even more. And estimated accrual is 2.5 years. So this, we've gone through stats review. We actually got perfect scores on the patient advocate ranking. It's gone through GI, surgery, palliative end of life care. Big thanks to Dr. Robert Krause, who's been my mentor throughout this process here in the room. And I think we've collected all the signatures and are submitting to executive committee this week, essentially. My big question, and obviously happy to take questions, but Something brought up at that HPV clinical trials mentorship talk was a concern about non-blinding. And so we took out this was originally a placebo-controlled trial, but it was going to cost about $300,000 just to make a syringe that matched the other syringe. And there was some hesitancy from actually patient advocacy and GI about unnecessary placebo sub-Q injection. So there's going to be no placebo. But there was concern about, I guess, non-blinding and knowledge of administration of lanreotide maybe affecting what a surgeon would do intraoperatively or even postoperatively. Even though we didn't see a lot of side effects in the phase 2 data, we think that it's going to be hard to tell just looking at a patient if they got the drug or not. So the only way that the surgeon's going to know is, whether they just know at the beginning of surgery. So for people who have more operational clinical trial experience than I do, do you see a viable way to blind surgeons to drug administration if it's given in the preoperative holding area?
It's just a single dose.
Single dose.
That should be relatively straightforward.
But not everyone's getting a dose. So there's no placebo. So
No, I understand that. But again, I think this is where the surgeon / investigator needs to have some kind of restraint not to try to unblind themselves.
We were toying around with like maybe the research coordinator comes to everyone who's enrolled preoperatively and, up to and including wiping them with alcohol, whatever. But I don't know. Again, I just don't have experience. I'd love to get thoughts on just minimizing bias.
I think Flavio's suggestion is the best, but I think at the end of the day, it's the criteria for defining the endpoint that have to be strict and rigidly followed. And if so, it minimizes the potential for any bias. I can't frankly see any intraoperative, changes in behavior. I think that's probably a non-factor because everybody does what their best to prevent fistula 100% of the time, I assume, right? So there's no like super extra thing to do. So I don't have a concern about that. I think it's just, I think the suggestion's a good one. I think that's the best you could do. And I wouldn't worry about it as long as, the endpoint parameters are sharply defined. Just one minor tweak for your inclusion criteria. It says histologic or suspicion of malignancy. I think malignancy needs to be removed because I'm assuming IPMN cases and small neuroendocrine tumors are viable you want them included. Technically, that's not necessarily.
We threw that in there for kind of the SWOG.
So I would say neoplasm.
SWOG angle. Yeah, that was what we added. The second one is a lesion with malignant potential.
Okay. I didn't see that.
That's
one.
what that's the kind of covers the cyst and neuroendocrine.
Okay. And I'm assuming that, patients who have, the question or suspicion of malignancy and end up having pancreatitis, they'll just be included as intent to treat.
I think so.
Yeah, there will be some of those.
For sure.
So first of all, I think this is an important study and I think it definitely needs to get done because, the impact of fistulas, as you've shown, is worse survival, less chance of getting on adjuvant therapy, so forth, so on. The questions I have first is, so you're not including people who may potentially get neoadjuvant therapy on here?
So we were actually, that was not an exclusion criteria. Again, the data, at least from our center and from polling others, is that relatively few people in the distal setting are getting neoadjuvant.
Because it's standard where we are.
It's more and more, you're absolutely right. But again, it was a feasibility. We wanted to include as many people. If you think that.
In fact, I think most people will think that if someone has a body tail tumor, that they should have that stronger evidence of getting neoadjuvant therapy because they have a higher risk of having occult disease. And so I wrote down some, and the other one is, how are you going to standardize in terms of, because you're enrolling so many different types of patients, which will have different texture and duct sizes, which are directly related to pancreas fistula. So you have IPMN with soft gland, small ducts, potentially, in the pancreas cancer, which will be a bit hardened and, less likely to leak.
Great.
So I think quality control for a study like this is going to be important to understand like all the different variables that can affect pancreas fistulas.
Absolutely. So about the neoadjuvant question up first. So there is, I think, Sai, you brought it up at the last meeting. there is actually really good data showing a decreased fistula rate in the setting of neoadjuvant therapy in Whipples. The
Well,
data is
that's with
actually,
radiation though.
the data is actually not as strong for distals in the
I
neoadjuvant
see.
chemo setting.
Okay.
And, we talked about this a little bit at HPBA. I really went back and forth about stratifying pre-randomization based on pathology. But the thought was that it's a big enough study that those diagnoses, the ones that you mentioned, should kind of wash out in the randomization.
Well, but you could look at more things that we use standardized tools like the pancreas, the fistula risk FRS, score, whether it's high or low, and so not necessarily look at all these variables, but kind of look at the fistula risk score as a way to stratify people.
Yeah, so the distal fistula risk score was actually just published recently. It's a new trial. Interestingly, some of the factors are different than the open fistula risk score, and some of the risk factors are actually kind of opposite. It's actually cystic lesions have less of a risk of leak relative in contrary to Whipples. Again, I'm open to the pre-randomization stratification, but based on kind of polling the committee previously,
Andy's shaking his head now.
it just okay.
Steve.
Steve.
No one knows the answer. It's a big enough study. I agree with you. It'll wash out.
Yeah, Jonathan, Steve Behrman from Baptist in Memphis. And I think we talked about this a little bit before. I believe you said that there was not going to be any standardized drain management. I wonder if that should be reconsidered. I mean, there's pretty strong data from the Whipple population that early drain removal can actually lower the risk of developing a fistula. And I think there's also a precedence for having drain management as part of a study. The Porch trial out of the Netherlands mandated strict drain management as part of their study of looking at early imaging to based on certain parameters to diagnose a fistula early and intervene earlier. And so I think if we're, I could see someone easily saying, well, they're not measuring any drain amylase. There's 100 cc's coming out a day. I'm going to send the patient home for 2 or 3 weeks with a drain in. And that in and of itself can lead to ultimately a fistula. So I don't know. I would, from where I stand, I would strongly consider having to find drain management program. That for the Netherlands study, they had 90% compliance in that. So I think it'll be easier for surgeons to get on board if you define the parameters for drain removal.
I appreciate you bringing that up again. It's a tough one. There's data out recently out of Europe showing that, grade BC fistula rates are the same, whether you have a drain or not, period. But despite that, people are still living drains, at least in the US. I think Flavio's point from our last meeting, I guess, is what I keep coming back to, but I'd love to hear, again, people with more experience's perspective. And that's, if we're reviewing protocol violations for drain management, at the site level, given that there are so many different drain management pathways out there, it just make it unwieldy. And we want to make this as pragmatic as possible. But again, I'm open to.
I agree. I think it'll be a barrier to enrollment because if the center doesn't believe in that specific drain management schema, they may not enroll their patients.
And we're not standardizing the way you come through the pancreas either, right? So,
correct. Yeah, because
so there's going to be lots of variables here. And I think in some ways, Steve's point makes sense in the context of the blinding issue, right? So again, this is one because again, you don't want to be influenced your drain management if you knew the group they were in theoretically. But again, these are all things that are very valid points, but really hard to crystallize.
This is a great, Jonathan. I think, one thing highlights the actual real world challenges of doing a blinded placebo controlled study. People throw that out there like it's an easy, inexpensive thing to do. It's not. You could, however, have a card with 2 syringes that sits on the patient's somewhere. And if the surgeon happens to walk by, I mean, who knows? Like that's your blinding there. It could be something very simple that's not filled with anything. For the standard of care, and this is the challenge, to randomize people, if you're going to do a placebo at all, you have to be able to have equipoise at the other arm, like that there's no benefit. With a randomized trial, single center showing a benefit of perioperative pasireotide is a standard of care at my institution is to give that. So is that my standard of care arm then in that setting?
Yeah.
Or I have to say that in this group, that it was the highest risk part of the Allen trial. Will I now say you should get something that is not standard for what I normally do?
It's a great point. There were fisticuffs, near fisticuffs between Chuck Vollmer and Mike D'Angelica in Miami a couple months ago about this issue. To be clear, the protocol or this capsule is written as no lanreotide. So, and we didn't say no pasriotide, but I would assume that's what that means as well. In the survey, and actually, if I could, I'll just bring this up as a brief shameless plug. We have a survey that we're running, HPBA approved, just about prescribing practices around somatostatin analogs and pancreas surgery. It takes literally 4 minutes. So if you touch the pancreas, please share this with your colleagues, take a picture. We need 5 more to get to 100. And we'd love to get to that just magic 100 number. Anyway, but to the point, very few people are using pasriotide, at least with the 95 respondents have given data thus far. It looks like about 20% of all respondents are giving some type of somatostatin analog, and about 7% are using pasriotide. So I guess a question, maybe if I could ask you a question back, is would you be willing to not give somatostatin analogs in the setting of this trial to your patients?
The challenge with pasriotide are cost and actually like supporting patients through the nausea that they're going to have. And so I think that's one of the barriers at a lot of places. I mean, I believe in it, so I push it, like, you know, and but I like this because it takes care of everything potentially preoperatively upfront with one dose, and we don't have that. Okay, you're post-op day 3 after your distal spank, you can now go home, but we have to stop your pasriotide because I don't want to send you home with it. So I would support it for that alone.
Okay.
You know?
Quick question. Do we have any incidents of, is the lanreotide as a metagenic as the pasriotide?
Not in our data.
Yeah.
Not in the phase 2
Yeah.
trial data.
And
The largest complication was rash at the skin injection site.
can you comment on the cost of the drug? And I know the answer, but just for the audience in terms of.
Yeah, so when Ipsen was making it, it was $9,000 was the cost to our institution. Now it's generic and it's $6,000 cost to institution. Those are our numbers. I don't know if that's true
Yeah.
for.
What about
other
in
centers.
the context of the trial?
Well, it's supplied by the drug company,
Yeah.
so zero.
Yeah.
Hopefully, plus
So-
distribution costs.
Yep.
Yeah, so say Ethan from UT Southwestern. Have you thought about mandating exactly where it should be injected, or at least saying that they can inject into the abdomen? That's another way that a surgeon can easily be unblinded when you take back the covers to position the patient and they have a nice little injection site on their belly.
It's a great point.
Or considering, again, just non-abdomen and then putting a Band-Aid on everyone's butt. you know?
I love that idea. We in the pre-op we did, thigh, buttock typically, but I like the Band-Aid on everyone. It's so easy. And yeah, thanks for the idea. Yeah. Oh yeah.
That was more for incision. That was lap versus open. Yeah.
It's an incision.
And then my other question is have you considered looking at time to drain removal as a secondary outcome?
Yeah, so there's a lot of surgical details that are going to be in the protocol. That among them, a lot of other surgical outcomes things we care about that I had to actually really like. Length of stay was actually very complicated to get through stats review because it doesn't mean the same thing. Like we all know what length of stay is, right, as surgeons, but they're like, how many people are dying before? Is that going to, before discharge? Does it have to be alive at discharge, kind of thing? But yeah, so there will be a lot lot of other kind of.
I think the
data.
key for success is going to be getting the word out and understanding, like, because I don't know, like within the NCTN network, whether patients will be enrolling pancreas cancer patients in the study, because they'll want to enroll them on other therapeutic studies, with chemotherapy and novel agents. And, so I see like within this framework, the IPMNs and other indications for trial enrollment. But, it's going to be about, once the study's open, is really, kind of partnering with some of the other cooperative groups and specific reach out to high volume institutions, and really being a champion in terms of reminding people the study's open, because it's a large sample size. And, I think the challenge is going to be which patients getting enrolled.
We're thinking NCORE is going to play a large role
Yep.
and help with it.
But I think this is actually a great opportunity to engage surgeons in cooperative group trials. And we learned this from the ECOG CIS trial, the 2185, because again, we saw oncologists that weren't necessarily, interested or knowledgeable about that. And this could be a chance to get some of your surgeons at your cancer center involved in this.
All right, thank you.
Thanks.
So our final presentation is, again, from someone who needs no introduction. Preoperative therapy for resectable colorectal liver metastasis from Dr. Gulami, Northwell Health. Surgical oncologist, unlike what Philip said. Thought she was a medical oncologist. Oh.
You put it on desktop?
Did you put yours on there?
I did. Yeah. I don't know if
It should be on
is
the
it
desktop.
surging? Oh, got it now. Okay, it's not here. Perfect. All right. I made poor Otto go through this today. All right. I'm gonna just skip the background, or side. Do you want me
Yeah,
to go?
no,
Because
yeah.
I do really think that we've talked about this sort of ad nauseam.
Yeah,
but-
we want to get to the
So we
discussion.
can, in terms of, let's just go through, I'm just going to go to the schema. So essentially, this is a phase 3 study. It is not a phase 2. It's designed as a phase 3 study in which we're looking at really the treatment of FOLFOXIRI versus FOLFOX in patients with resectable liver-only metachronous colorectal liver metastases or synchronous colon liver metastases with, right now, the way it's designed was fewer lesions and very limited to MSS tumors. The patients will at baseline get an imaging with either CT or MRI, the way it is done in the community, and then will be randomized to 6 cycles of FOLFOXIRI versus FOLFOX. Then they will go through another restaging imaging and then follow with the liver resection. We will allow for ablation in conjunction with resection as it is standard of care. And then after the resection, they'll undergo another restaging imaging and then undergo their adjuvant portion of the treatment, which we are asking for it to be the same as the neoadjuvant sort of preoperative chemotherapy with FOLFOXIRI. However, in the FOLFOXIRI arm, you see that we will allow for dose modifications due to toxicity by the investigator, including CAPOX. So trying to be as pragmatic as possible in the adjuvant setting. And the bottom one you just see there will just get FOLFOX, which is the same as they got in the pre-adjuvant. The completion of the adjuvant therapy should then allow for a total of 12 cycles, the way it's written. And then the surveillance will include CT, MRIs every 3 to 4 months, which is per standard. And I think the other thing to note is that we will have patients receiving, actually undergoing serial ctDNA, so that we really have a prospective, basically collection of this marker so that we can really study this, which is a big component of this trial. With regards to the primary outcome, we've talked about this a lot too, and I'll have a point about that. This is sort of what I discussed at the task force meeting, is primary outcome is DFS. The secondary outcome is treatment-related choice toxicities, overall response, path response, immune cell infiltration, as well as the ctDNA dynamics pre and post resection, and as well as overall survival. Stratification factors so far are the location of the primary tumor and the BRAF status mutation. So with regards to the patient population, right now the inclusion includes all patients with resectable liver-only metastases. We had a long discussion about what is called resectable, and we're going to keep it as simple as possible. That is going to be defined by the operating surgeon, which just we call that right now, as long as they have an adequate FLR with an inflow, outflow, and biliary drainage. And the cases discussed at the multidisciplinary tumor board. This is mainly for community centers if there is any questions, since there is not going to be any central review of the imaging. Liver-only disease needs to be just upfront resectable, so in a single stage, so we won't include the patients that undergo two-stage resections. The primary tumor is allowed to be resected in a staged procedure fashion. So if you're doing liver first and then primary last, that will be allowed. Grade 1 or less neuropathy is really essentially because of the FOLFOXIRI requirement. And we discussed no prior oxalic treatment for at least 1 year or greater to really avoid the toxicity in these patients, and then no extra hepatic disease. If you have a questionable lung lesion, we are really leaving it up to the treating provider. If they think it's suspicious, then further sort of workup, including a biopsy, could be indicated, but will not be a requirement nor an exclusion. So with regards to the statistics, this was something that actually when we presented to the task force, they wanted to see a 90% and an 80% power. So what you see here, this was what the stats that we did with Catherine and the SWOG group here. It was based on essentially the 18 months median DFS. It's from the Nordlinger trial. We said that we were going to enroll about 6 to 7 patients per month, but I think it's pretty reasonable in terms of feasibility, with a one-sided alpha and 90% power and a 3-year follow-up and a 10% ineligibility rate. And this includes patients who maybe have a disappearing met or somehow drop out or have some toxicity for it. That it would require, with a hazard ratio of 1.3, we would need a total eligible 562, or a hazard ratio of 1.5 would be 302, with a total enrolled is 336. Now, the task force actually asked for an 80% power because they thought that was more reasonable. So then I did this sort of by myself with the 80% similar, sort of like eligibility and ineligibility rate. You can see those two numbers. So the hazard ratio of 1.3 would need 385 total eligible patients, and 1.5 would be 190. So I think that's a pretty tough hazard ratio. And so I would love to hear from the audience here, what we think about those two hazard ratios at the end, because I do think that we don't want to shoot ourselves on the foot by just being too aggressive here as well. I'm not sure if, a full FOX, I'm hoping to see some evidence and improvement, but I think that is pretty rigorous. So I think I mentioned the really, one of the really key factors and the big benefit of having such a trial is that we are able then to collect ctDNA in a prospective fashion, which has not been done in, in less than 30 patients in a circulate in sort of in one of the studies. The patients right now, we know that obviously with resectable oligometastatic disease, have it's definitely a prognosticator, but it's not a predictor. And I think this would really help us to understand, the dynamics better in this specific setting, and then understand it as a surrogate endpoint or biomarker for future trials, which, as Philip mentioned this morning, is still sort of, controversial whether we can use it or not. And then I really wanted to highlight a couple points about OS versus RFS, DFS. I think a lot of, there's always this argument made that, well, FOLFOX did not show OS benefit, in the Nordlinger. So why would you, not look for, why would you not use OS but DFS as an endpoint? And I think we sort of, I would say that, we can't, I think this is interesting, right? But when you look at the adjuvant and even like the advanced setting, FOLFOX actually has not shown any OS benefit, even in phase 3s in the metastatic advanced setting, yet it is standard of care. So I think we're sort of like very tough on ourselves, and especially in like the surgical oncology world sometimes, because actually this OS versus DFS comes more from surgeons, believe it or not. And I think in general, RFS is really looking for like drug efficacy. OS is really like drug sort of efficacy plus salvage therapy. So I think because there's always salvage therapies in these selected patients who, once they recur, there's still other options for them. It's very hard to capture that within the OS sort of as an endpoint. So I think that is always a limitation. Obviously, we also know that it's very difficult to run trials that, on such a large scale to make OS and benefit. So I think it's just almost impossible, and the feasibility becomes almost zero. The other point, and this is actually a study out of MSK, that came out looking at, basically, it showed that essentially that RFS may not be like the best predictor for OS in this patient population. In the same actually publication, they do show that the early recurrence in these patient subgroups is associated with a worse prognosis. So I think, we do know that these patients that recur early do worse. So I think it's not completely irrelevant to use RFS as an endpoint, which is just going to be the only feasible thing that we can offer. So, and I think we just basically what the discussion went for the task force meeting, and we really didn't get much of input with regards to the 4 or fewer lesions. We talked about other things, but I'm still thinking, I would love to hear still whether it should be really limited to 4 based on the Nordlinger study that had those 4s, or should we include, patients with, extra number of lesions as long as they're resectable. I think that would make the feasibility better, but it would make the population a little bit more heterogeneous. The other things that we talked about is, what about if the lesion is very small and you're getting 3 months of preoperative chemotherapy? What do you do with disappearing mets? So I just would love to hear sort of some thoughts about that. And then just to increase the feasibility also, like, would you allow for 1 cycle of chemotherapy prior to enrollment? Just when you're out in the community, the patient has already started on 1 cycle of FOLFOX, is it okay to still enroll that patient and then continue on whichever arm they will end up? So that's essentially the presentation. We sent a survey out and hopefully should have some results by next week or so.
Open for discussion. Dr. Mayo.
So maybe it was a typo, but I saw you had a FOLFIRINOX in there versus FOLFOXIRI.
Oh, that's FOLFOX series.
Okay.
Okay.
So I just
Yeah.
was curious.
Yes, probably.
Okay. And
that must be
then back to your questions, I think, to standardize it with what we know from, the Northern J trial, I think, 4 Mets is fine. And I don't think trying to break it down into other higher numbers is really going to, improve. Those are patients that often we're going to want to give more chemotherapy to in general. I think allowing a cycle or so of chemotherapy will be very important. I think especially trying to capture patients in a cooperative group setting and from afar who may get their first cycle and then find out about the trial. Like so we found this for our trial. We had to modify it for lymphatic cholangio. And then I think you go back to your questions. There's one other one I was the fiducial.
Yeah.
I know people in their hand, like raise your hand for me to place fiducials for small lesions. I mean, I do. I say people talk about it, but like it's rarely done. I mean, it's hard to do. It's rarely done. And I think that even the ones you think have disappeared, you can sometimes see them in the operating room. So
yeah, I guess it's just only for the part that you may not like. You have been in the operating room where you're like, I don't know if this is really a lesion or not.
I wish you have.
Right.
I don't think you can mandate it in any fashion.
No, it's just like it's a thought, right? Allow it to just make. We're just trying to make sure that we don't have disappearing things and, not, then it says fully treated or not, right? We know that with disappearing mets, there's about 25% of that lesion to have some cells still remaining, right? Viable cells in there. So I think that that's just my concern, that they're not really treated fully NED, like with the rest of it. So it's just an idea, like you can suggest it. We're not going to like exclude patients, but just.
So I have a different feeling about the number of lesions. So I think the study is going to be very hard to get the sample size. And I think you've got to lower all the barriers. The other thing is, if you look at the ERTC study, perhaps 4 or less lesions is a subset of patients that are favorable and are less likely to respond to systemic therapy. And if you include patients who are higher risk for recurrence, maybe if there's a signal, you'll find it. And so I think for those 2 reasons, I would say expand the inclusion to resectable lesions, and you'll have to define what that is. And because it's 500 patients, it's not going to be easy to enroll on this study. And so if you limit it to 4 or less, it's gonna struggle to accrue.
I kind of agree with that sentiment that
Yeah.
I think 7 patients accrual a month is optimistic and going to be challenging. So I think you have to think about easing the barriers there. I think the small lesion thing it's impossible to, to deal with, except just to make a recommendation. You can make a recommendation that that area be resected if feasible, but you're not going to get beyond that. Did I see somewhere where you were allowing ablation?
Mhm.
I worry about that a lot, actually, because the control for that, you're going to control for the size, the quality, that just when your endpoint is recurrence in the liver. I don't know. That
Yeah,
just
the
makes
problem,
it makes it less homogeneous.
I think the problem with that is that, in general, I would say the majority of cases that I do, and like everyone that you ask, is that we really use a combination of both. So if you have 4 or 5 lesions.
So you're going to
and-
allow them to ablate more than one lesion then?
Yeah,
Or-
I mean,
so,
I
so
I
they have
think
to
you need
treat, so every lesion has to be resected or ablated.
Correct.
So it's okay. So
Like
I
what,
didn't-
like basically.
But I think
the
we have to have
way
at least
you-
one resected lesion. Is that
One
correct?
is, the minimum
I
is
see.
one
Okay, I
resected
didn't
so
get
that
that.
you can,
Okay.
but you can, because
Okay.
otherwise.
You're
if
going to
it's a
have
deep
guidelines
lesion-
on size. That's
Yeah, and like
oh,
margins
like
of what we
3
think.
centimeters or less, or that
Correct.
kind of things. Okay.
Yeah, like typical things that
Is
we would
yeah, that's
recommend,
going to be
like,
pretty important. And this is
Yeah.
going to be investigator determined relapse.
Uh,
How's
based on-
relapse going to be determined?
oh, based on
By who?
scans.
By the investigator?
Correct.
Individual site investigator.
Yeah, because we're not reviewing scans.
Right.
Yeah, correct, yes. Can I just, sorry, one comment? So on, I go back and forth. I initially started this with like thinking 4 or less is really the way to go because of statistics and wanting it to keep it pure and just like the best design possible. And I do think that feasibility, I mean, the numbers I'm seeing, it's becoming
Yeah,
like.
no,
more and
it's the
more
classic
difficult.
conundrum, right?
Yeah.
Design versus feasibility. And I
Yeah.
think there was a question about, I think maybe it was with the colorectal subcommittee about, is FOLFOXIRI the right agent for, lower burden of disease? And, but I'm coming around to the point that we really should try to open this up, especially with those numbers.
I mean, and again, I'll make the point again. I think we've done the prospective study with 4 or less lesions. It's a favorable subgroup, and
There's something.
they're probably not. You're not going to see an OS or RFS there. You may not. And so if you make it a higher risk
Yeah.
group, then if there's a benefit of systemic therapy, that you're more likely to see that there.
Yeah, I think the comment on that side was that if you have like 7, 8, or 9 or 10 lesions.
Well, you have to
let's say-
pick a ceiling. You
What's
can't
the
have
ceiling?
20.
Like,
Yeah, what's the
but I
ceiling?
don't know
mean,
what the
that's why,
ceiling.
like, I
is.
Well,
like
I-
the 4 or 6.
Well,
Because I
you
think
could- that's a
we
dis-
to 6, 7. Now you're
Right.
like a couple ablations are happening in there now.
Sure.
So
Right.
that's where,
Yeah,
Well,
you know.
one ceiling is we're doing this all in one stage, right? I don't know if you mentioned.
We
you
are
mentioned-
doing it all.
Yeah,
in
so
one
not
stage,
two-stage
So
hepatitis.
you can't do, I mean, and we can cap it. I think the caveat to using 8, 7, or 8 is that the counter argument was that when you having a young patient in your office and there's like 8 or 10 lesions, that patient most of the time now, given the advanced setting data, will be started on like the triplet.
Yeah.
For a deeper response. And so that's just reality. And then is there going to be a bias, or is there actually, like equipoise to give you only FOLFOX when we know that response rates are better? I think that's the issue I see. That's
But-
the trade-off.
gotta make it broadly
But there are
applicable.
lots of those patients. So if there's
Yeah,
3,
there's a lot.
if there's 7 lesions and there's a chance that patient's not going to get randomized to this, that oncologist may just treat off protocol, but then there'll be other patients
Yeah.
that
You
do
won't
get
capture
randomized.
everybody.
Yeah, you won't capture everybody.
Yeah.
It's the balance of making
And then
it broadly
stratify by number.
applicable.
Yeah,
but
high
You're
and
gonna
low.
have to decide
You have to lower
on
the
the number of
barriers.
lesions, and you're gonna have to define small lesion.
Yeah.
I mean, like, you're
Small
gonna
is
have
less
to,
than
you're gonna have to put numbers on them in some way.
10?
And that's a
Five.
challenge, and you're gonna have to say
I-
no
I think-
more than 1 or 2.
I think the
ablations.
ceiling is, resectable lesions,
Oh, yeah.
and then people will enroll what they enroll, and you're going to learn.
Yeah, I just also want to put my support behind increasing the number of lesions beyond 4, because I don't know what everyone else thinks, but I'm not sure I have equipoise for this for solitary liver mets. right? I mean, I don't know if I would randomize them for chemo. I wouldn't give them chemo at all. So the more lesions you add, the more likely I'm going to open it at my center, enroll patients, the more likely you're going to get people to actually accrue numbers just based on patient availability, but then also surgeon bias.
Cecilia, you're going for the point of you don't give preoperative chemo at all in that population. You would just take them to resection.
I would, if it was a solitary
Yeah.
liver met, I would just
Right.
take them for resection. And so I'm not sure. And if they got chemo, they may not get 6 months total.
Right.
And so, I think not only feasibility of enrollment because of opening the potential patients, but also opening surgeon or minimizing surgeon bias and actually accruing patients for this trial. And then my other I just wanted to clarify. So you said no chemo within a year. So we are, to clarify, the patients who have early recurrence after adjuvant or neoadjuvant therapy that recur within a year will not be eligible for this trial. Okay.
Because that's a very different subgroup, and I think they are the worst outcomers.
Let's get one more question in, Javindra.
Two things to consider, please, because you're allowing radiation ablation.
Mhm.
I think there's a concern that beyond resectable will be enrolled, especially because these are site-specific determinations, no central review. That's what happened in 1505 for pancreas, for example. Borderlines were enrolled on resectable trial. My concern is that people will look at 8 lesions and say, yeah, we can cut it out, we can burn some, let's put them on this trial and see what happens. And you might end up with a bad population. Second, why don't
That's
you
what we're
pick
doing.
1.5 hazard ratio to keep the sample size to 200-ish?
You prefer the 1.5?
400 plus patients is a lot.
It's gonna be really, really hard.
Yeah, but it's also, do we really think that we need to get that much out of volcanoes? I mean, that's a hard sell, I think. Am I the only one in this room that I think it's almost impossible to reach that hazard ratio? I mean, there's a lot of med-onc trials that, with 0.75 or 0.8 almost become standard of care.
What did you?
Like, I
have,
really,
for
just, that's a really significant amount. That's 0. I don't know. I just would love to hear that.
I'm
like-
a big opponent of putting hazard ratios to fit your sample size because it doesn't make sense. You have to follow your belief in the science
what
and
I'm- yeah,
and the therapy. So
exactly, yeah.
I agree with you.
Yeah. It's,
But that's the reason why the trial's no good if it doesn't get done. So you have to find a
Increase
way to liberalize the inclusion, I think. I think that's.
Yeah.
I think
but
that's
also
the
there's no
point.
reason, I think, to do necessarily 90% power. Like, is
No, I
really
agree.
80% power
yeah.
inadequate?
Yeah.
Like, I don't know. It's maybe Sarah's.
All right, we're gonna stop
Okay.
there. We have the GI meeting for those interested.
Thank you.
Starting at 4:30. Great discussion, everybody.